Because of the huge overlap in causality, namely E. coli, urinary tract infections can really be addressed as a group. That is to say, cystitis is E. coli, pyelonephritis, prostatitis, and perinephric abscess, all predominantly with E. coli, all with a fever. All UTIs can present with dysuria. Frequency, urgency, burning dysuria, frequency, urgency, burning dysuria may be a fever. And the best initial test for all of them is a urinalysis, which you're looking for white cells. Now, you don't want to make the mistake of saying urine culture first. That creates a lot of false positives. One of the most common wrong answers to say urine culture without a urinalysis showing white cells. The most common cause of all of them is E. coli, and quinolone is the best initial therapy for many of them. Now, the anatomic defects that leads to urinary tract infections are stones, strictures, tumor, obstruction of any kind, like BPH, or diabetes because you're slightly immunocompromised. Neutrophils don't work well if they're in too sweet an environment. But the anatomic defects, stone or stricture, tumor, or obstruction, is the same things that cause all of these urinary tract infections. In addition to stone, stricture, tumor, obstruction, is things that act as a foreign body. And the Foley urinary indwelling catheter is definitely a super big cause of UTIs as a foreign body. Big time. You should not be placing this into a person unless they have obstructive uropathy. Foley catheter is not to be put in just for incontinence. That is wrong. That is the most common wrong answer. What is the reason? Why did you put that Foley in? They're incontinent. We'll put a diaper on them, put a condom catheter on them, but don't put a Foley in because Foleys kill people. They cause urinary tract infections, and we don't want to kill grandma in the hospital or in the nursing home with a Foley just because the nurses don't want to clean up. Big question. Neurogenic bladder is one form of obstruction, such as happens with multiple sclerosis, neurogenic bladder. Frequency means multiple episodes of urination, of micturition. Polyuria means an increased volume. So diabetes and diabetes insipidus, diabetes mellitus gives polyuria. Urinary tract infections and urethritis give frequency. In cystitis, you present with dysuria and suprapubic pain or discomfort and the absence of fever or just a little mild fever. Now, men have anatomic abnormalities in almost all cases. Women most often don't. And this is because a man's simile should not be having urinary tract infections. It is common for a woman to have it without any anatomic abnormality. However, when a man has any form of urinary infection, you must do imaging testing. Now, both are diagnosed initially with a urinalysis with greater than 10 white cells, and the most accurate test is a urine culture. But this is not how you determine the etiology of that cystitis. The only way to determine the etiology or cause, to know whether or not it should be fixed, is by doing sonographic or CT imaging. Trimethoprim sulfamethoxazole is the initial therapy if we know that the resistance is low. If we know resistance is low, if you don't know the resistance, then it can be trimethoprim sulfa or ciprofloxacin or fluoroquinolones. Cephalexin can also be used for many types of E. coli's. Nitrofurantoin, especially in pregnant women, and some people would say that nitrofurantoin is the drug of choice in UTIs. If all of these are in the same question by itself, you cannot be asked to choose between them. They're all good. And all beta-lactams are safe in pregnancy. Beta-lactams are penicillins, cephalosporins, carbapenems, and aztreonam. Now, I'm not saying to use carbapenems and aztreonam for a cystitis in a pregnant woman. I'm making a general statement that all beta-lactam antibiotics are safe in pregnancy, and so is nitrofurantoin. A 36-year-old, generally healthy woman comes with urinary frequency and burning. The urinalysis shows greater than 50 white cells. What's the next best step in management? The answer is 3 days worth of trimethoprim sulfa. That's because 7 days is not necessary unless there's some complication like a stone or a stricture or a tumor or obstruction and an anatomic abnormality. That's when you extend it to 7 days or any complication. And remember, If a man has a urinary tract infection of any kind, it's always considered complicated. Urine culture is not necessary unless somebody has recurrences or fails to resolve. And a sonogram or a CT of the urinary system in a woman is not necessary on a routine basis. There's no need of culture or imaging when symptoms of cystitis are clear and there are definite white cells in the urine. Dysuria also occurs with pyelonephritis. Frequency, urgency, burning when you urinate, and dysuria. Well, then how are you going to know the answer? Most likely diagnosis is pyelonephritis. Well, it has to have flank, CVA tenderness, your sides. That's where your kidneys are. They're up underneath those ribs there and towards your back. Remember, the kidneys are a retroperitoneal structure. They're a retroperitoneal structure. They'll be up underneath your ribs back there. Also, the temperature is much higher. It's very unusual to have a cystitis with 102, 103 fever, and common to have 102 fever with pyelonephritis. That's because pyelonephritis is much more parenchyma, much more human meat there, inflamed, much more often bacteremic. And sometimes it's so uncomfortable that the kidney pain actually goes all the way through to your abdomen. Wow, you can feel it in front. The urinalysis will have high white cells, but so does cystitis. Imaging studies such as a CT or sonogram, this is very important. It's not that you need them to tell you have pyelonephritis. If you have a person with dysuria, flank pain, and white cells, you got pyelonephritis. The essential feature is two things for imaging. When do I answer imaging? One, the diagnosis is not clear. Two, it says, which of the following will allow you to prevent recurrences? Prevent recurrences. Imaging studies such as CT or sonogram look for anatomic abnormalities causing the infection. Wouldn't you feel bad if you had a pyelonephritis and nobody found out whether you had a stone that could be easily removed, or you had a urethral or ureteral stricture that could be easily dilated, and nobody told you, and then it recurred and you got bacteremic? You'd be upset. Find the cause and fix it. Treatment for pyelonephritis is with ampicillin and gentamicin. Well, why both? Well, that's because if you're an inpatient and you don't know what the etiology is, you don't have the microorganism sensitivity yet, the combination of these two antibiotics is excellent. And one of the things that's an extra here is you must remember, where do these drugs excrete out of the body? How do they leave? How do they exit? They exit through the urine. So when you give ampicillin and gentamicin, when they are excreted, they go in super high concentration in the urine and they can really kill off whatever bug is there. It's fantastic. Ciprofloxacin as well. And you change them based on culture and sensitivity. So any drug that would be effective for gram-negative bacilli would be good for pyelonephritis. So that whole list, and I'm going to remind you again: aztreonam, the monobactam, carbapenems, piperacillin, ticarcillin, third and fourth generation cephalosporins. Well, they'd all be good here. But how do we answer questions? These two things would be the best: ampicillin, gentamicin, quinolones. Prostatitis is dysuria combined with perineal pain. That's down below, hurt you near your buttocks there, your perineum, and tender prostate on exam. And if they want you to know the answer, they'll tell you this, or they'll say, which of the following is the most specific method of establishing a diagnosis? Prostate exam. You press on it, it hurts. Ouch, done. Diagnostic yield of urine culture is increased with the prostate massage, and you treat it the same way you would for pyelonephritis. Just go longer, go longer. Prostatitis is very difficult. It acts like a little abscess in there, and you sometimes have to treat with chronic prostatitis with trimethoprim sulfa or ciprofloxacin for 6 or 8 weeks for chronic prostatitis. Very difficult, isn't it? Think of it like an abscess. It'll recur if you don't. A perinephric abscess is pyelonephritis that just simply doesn't get better with appropriate therapy. So the bacteria escape outside the kidney and get accumulated underneath the capsule of the kidney. The kidney is a very tough capsule because the kidney is a very high pressure organ. What you basically look for is you look for a person who's got pyelonephritis, they're on antibiotics, and why is it that 5 and 7 days later they still have a fever? But the first thing you have to do is make sure the drug choice is correct. So when the drug choice is correct, you're using the right drugs, and the dose is correct, it will have to be described in the question that you're giving the right drug at the right dose, and it still fails. So when the drug choice and the dose are correct, failure of infection to resolve is an anatomic problem. So you do a sonar or a CT scan to find the collection. And you drain the fluid collection is absolutely mandatory because it accumulated while on antibiotics. So you can't give them just more antibiotics when it happened while they're on antibiotics. And culturing the infected fluid is absolutely essential to guide therapy because it developed while on antibiotics. Perinephric abscess is a very rare entity. It largely had to do with people who had untreated urinary tract infections. Our access to emergency antibiotics is tremendous, so perinephric abscess and lung abscess is a very rare entity for us. Nevertheless, though, unresolving pyelonephritis, scan, biopsy, drain, change the antibiotics according to the culture sensitivity.